This story is based on research and observation done by Mupenzi Eric related to health structure in Africa, basing to Rwanda. It is additional recommended to all African countries where they have insufficient doctor-patient ration. According to the World Health Organization, one doctor should be assigned to 1,000 population. While some African country, for instance Ghana, 1.4 doctors are assigned to 10,000 people. Due to the insufficient doctors, healthcare service in African is very poor, where patients lose their life, postponed rendezvous, losing hope for patient to recover, become a burn to their family due to continuous changing appointments, and patients abandon their rendezvous due to financial difficulties. What more, most researchers recommend that a country should increase the budget in order to overcome.
A man who had been in a terrible accident was rushed to the nearest health center, his knee shattered and bleeding heavily. A nurse examined him quickly, her face tightening with concern. The injury was far beyond what the small clinic could manage. "We need to get him to the hospital immediately," she told the team. "He needs advanced care." Within minutes, he was placed in an ambulance and transported to the district hospital. As soon as they arrived, orderlies rolled him straight into the emergency room. Inside, the emergency doctor was already preparing. He pulled on gloves, gathered instruments, and positioned everything he needed to treat the severe open fracture.
The doctor was fully concentrated, working carefully on the injured man's shattered knee. Knee anatomy was completely different from head trauma, and the doctor needed precision. "Ahoo!" he exhaled, wiping sweat from his forehead. "Give me 5 minutes," he told the nurse. But before he could finish stabilizing the first patient, the emergency doors swung open. "Doctor, we have a new emergency case," the nurse shouted. "The ambulance just brought a patient, severe head injury." They rushed the new patient in, and the doctor made a quick decision. The first patient was wheeled out of the emergency room to create space, but he still needed transition time and was not fully stabilized. Hospital Management Crisis Meeting. Scene. The atmosphere in the conference room was heavy, shadows stretching long across the polished table. Just hours earlier, a patient had passed away in the emergency ward, and the loss sat on everyone's shoulders like a silent weight. The hospital director stood first, voice sharp with frustration. "Director, we cannot continue like this. Another life lost. Our community trusts us, and yet we are failing. Doctors are not working with enough care or urgency. This is unacceptable." A murmur rose from the medical staff seated along the table. One of the senior doctors, still in his scrubs, leaned forward. Exhaustion showed in his eyes, but so did conviction.
Senior doctor. "With all due respect, Director, we do care. We give everything we have to save lives. But sometimes we face impossible transitions. When an emergency interrupts another, the shift in focus is brutal. We lose critical seconds of concentration moving from one case to the next." He paused, letting the room feel the weight of his words. "Senior doctor," continuing, "and when patients come from lower-level health facilities without proper information, no diagnosis notes, no vitals, no report on what was done, we start blind. By the time we gather what we need, the patient's condition may have already worsened." A younger doctor added quietly,
"Young doctor, we need better communication, a clear referral system. Information must arrive before the patient does. That would help us prepare, stabilize, and save more lives." The director looked around the table, his tone softening. "Director, then that is what we must fix. Communication, preparedness, transition time. We cannot change what happened today, but we will change what happens next." The room fell silent, not in defeat, but in determination. A new plan had to be built not from blame, but from understanding. The hospital board had reached a breaking point. Too many emergencies, too many losses, too many misunderstandings between doctors, nurses, and administration. So they hired a team of management scientists, specialists in systems thinking, workflow engineering, and crisis response design. Their mission? Build a new model capable of lifting the entire healthcare service to a higher level. The scientists arrived with laptops, flowcharts, and notebooks full of theories. But when they stepped into the hospital corridors, crowded waiting rooms, exhausted staff, alarms echoing from the emergency ward, they realized this was more than a research project. It was a rescue mission. They worked day and night. They followed ambulances, observing how information flowed or failed to flow from small clinics to the main hospital. They shadowed surgeons, learning how switching from one emergency to another could break concentration and cost a life. They sat with nurses, listening to frustrations about communication gaps and delayed equipment. They spoke with management about budgets, policies, and the pressure of public expectations. Bit by bit, the pieces of a solution formed. Finally, after weeks of intense analysis, they unveiled the Integrated Emergency Coordination Model, IECM, a system designed to erase the very challenges the hospital had been facing. Key elements of their model. 1. Pre-Arrival Information System, PAIs. Ambulances and lower facilities send real-time patient data, including injuries, vitals, and needed equipment, before the patient arrives. Doctors gain transition time to prepare mentally and technically. 2. Rapid Transition Protocol, RTP. A 3 to 5 minute structured pause, allowing doctors to switch safely between cases. Prevents loss of concentration and reduces fatal errors. 3. Centralized Emergency Command Unit, CECU. A small team monitoring all incoming cases, distributing workload, and preventing unnecessary interruptions. Nurses no longer rush into operating rooms without coordination. 4. Team-based rotational workflow. Doctors rotate in micro-teams so one can take over when another needs transition time. No patient is left waiting. 5. Transparent Communication Dashboard. Clear visual indicators showing case priority, staff availability, and resource usage. Management stops guessing and starts supporting. When the scientists presented the model, the room fell silent. Doctors nodded slowly. This was the system they had been needing. Nurses exchanged hopeful glances. Even the director, once harsh and reactive, leaned back and whispered, "This could save lives." For the first time in months, the hospital felt a spark of hope. A new system, a new rhythm, a new chance to protect every life that passed through their doors. In the model presentation, the scientists assured the hospital management that this new system would not require any additional budget. Instead, it relies on improved coordination supported by model-based simulation. Beyond enhancing emergency operations, the model also streamlines the scheduling of medical appointments by aligning them with each doctor's real-time availability. Through the integrated information system, patients can be transferred to the hospital for appointments only when the appropriate doctor is available. Additionally, the system enables reverse referrals from higher-level hospitals back to lower-level facilities by automatically sharing patient information, clinical notes, and prescriptions across all levels of care. This idea was created by Mupenzi Eric. It is dedicated to all African countries striving to improve their healthcare services. Thank you for your time. If you appreciate this concept, please consider subscribing to this channel. Your support helps us grow our community and continue sharing impactful innovations.